So I'm Gilad Litvin. I'm an ophthalmologist. Um, I studied medicine in Israel, in the Hebrew University in Jerusalem, and continue on to residency here in the Meir Medical Center under the supervision of Ehud Asya, and a subspecialty in retinal surgery. And from there on, I went to a career developing medical devices. My first patent I drafted in the final years of my public service in the health system here. But since then, I've devoted more of my time to developing medical devices and much less to practicing medicine. Currently, I do 1 day a week where I see patients and perform procedures, and the other part of the week I spent on developing these inventions of mine. Sure. So I drafted this patent and submitted it in 2015. It is my idea. It's the second patent I drafted. It combines my understanding of chemical engineering and biology. And I think for the first time, a completely synthetic implant to replace the cornea was developed. Until now, in order to integrate between the artificial and our own human body, some form of carrying tissue harvested either from other individuals or even from other animals is used in order to integrate between the synthetic and biological. And for us, for the first time, where I was able to develop an artificial cornea that uses only synthetic materials and integrates within our own eye wall. So this unmet need is, it depends on geography. Yeah, if you go to areas where the medicine is not very good and cornea banks or organ implantation is scarce, and this is over 50% of humanity, you have no access to corneal tissue. So first of all, in order to give access to this huge part of humanity who has no access, of course, if you have a completely synthetic implant that can stand on the shelf, can be transported, and so forth, you can solve this issue. So this is one unmet need. And the second aspect, if you even go to developed countries with very good medical care, you'll see that about 20% of corneally blind patients aren't suitable for corneal transplantation because of medical reasons. They either will reject this corneal transplantation for sure, or other medical reasons that don't give a high chance of acceptance of this transplanted donor tissue from a deceased individual. So 20% of the patients aren't suitable for corneal transplantation, and there are about over half of the world that has no access. So initially, this is the unmet need. These are our patients. I also believe that because the optics that we can shape and mold is something predetermined, and that's contrary to harvested tissue, which when you take an optical tissue and try to suture it very precisely in place, there's always distortions. And the optical distortions, about a quarter to a third of the patients can take a year to wane down. So for the initial year, they don't see well. Anyways, here we have predetermined optics. The patient that we did, the first initial patient, the minute we took off the bandages, immediately he saw to his potential, which is also an additional, let's say it's not an unmet need, but a problem or an issue with corneal transplantation that we are trying to tackle. So of course, in a clinical trial, I'm not the investigator. We approached an investigator here in Israel, a professor called Irit Bachar. She's a very experienced corneal surgeon and the director of one of the departments here for ophthalmology, a well-known worldwide researcher and surgeon. She found the first patient, which she thought was suitable, of course, according to a protocol that we drafted with inclusion criteria and exclusion criteria. And you have to understand, when you work with a site like this, it's always in collaboration. So if there are any things that we don't agree, we sit down and we think together how to. So we finalized the inclusion and exclusion criteria, and after eventually finding the appropriate first patient, we trained twice together when I actually taught her how to perform this, and also observed her doing it twice or three times, making sure that she feels competent. And when she felt competent and sure that she could go to the procedure, we scheduled the surgery. There was an assistant, not me, also very experienced surgeon sitting by her side, but I was in the room. We received a special authorization from the Ministry of Health for me to be there and view and help. And I tried to give my advice, every few minutes, look within the microscope, tell her, listen, you're doing great. Listen here, pay attention to this and this. But all in all, it took about an hour net, the whole procedure, which is not very long for a corneal surgery, or other previous attempts were always longer for artificial corneas, hours of surgery in order to implant. Here it was a very simple and straightforward procedure. And the day after, the patient said that he slept well, he had no pain, and he hasn't had any pain since. And if you look at one of his interviews, he says, listen, all the previous transplantations where I failed, immediately after the procedure, my eye was very, very painful, but here I saw and there was no pain. So an additional advantage that we found out from this guy, it's not planned, but at least we understand, after the fact that he feels well. And his vision has stayed exactly the same, stable for the past 2+ months since the implantation. His eye is quiet, there's no inflammation or infection. And as I said, his visual acuity is stable. And he's extremely happy seeing some of his grandchildren for the first time ever, being able to dial on his phone to his friends, making his own coffee, small things. But this is something very important for a 78-year-old man who has been blind for the past decade. I was present. It was the culmination of 5 years of very hard work and a lot of anxiety and excitement, and a lot of things we had to push through, difficulties. It's a very ambitious project. So seeing that moment when he started to read the digits off the board, it was, it brought tears to our eyes. I think that the patient himself, it took him about a couple of hours to understand what has just happened. He was the most indifferent in this room, but I think it was because he was very shocked. And later, when I talked to him, he was much more excited. I can say that both me and my partner, shed a few tears after working hard for this project 5 years, but also the department director, that surgeon that is the investigator in our trial, was also very moved. So that's the summarize. It's a very moving, but also objectively we could see the difference, and it was unbelievable. So we've received approval in Canada, and we're going to initiate the trial there, both in Vancouver, the University of British Columbia, and the University of Toronto and University Health Network Toronto Western Hospital. These centers will be led by the local professors, all of which are leaders in their field worldwide. Next Sunday, we will do the upcoming implantation here in Israel, the second one. That one is planned for this Sunday, the 21st, I think, and we have also an additional plan for the 11th of April. And I believe that about then, the beginning of April, implementations will start in Canada. Except for that, we have submitted requests for the Ministry of Health in Netherlands, for the FDA, and for France. So all together, we applied for 50 patients. The FDA asks for at least 20. So I believe that when we reach 30 patients, we will stop this trial and follow up for a year and then submit to the FDA to get approvals. Once we get these approvals for the initial set of indications, people who have failed previous corneal transplantation or are not suitable for one, we will go after primary indications probably and submit a larger trial to prove better efficacy and safety. So that's our plan for the upcoming, let's say, couple of years.
And could you tell me what distinguishes this implant from similar other projects?
Sure. So I told you before that we don't rely on any donor tissue. So when we look at previous devices that have received approval, we have actually two that have approval until now. One is called the Boston KPro out of the Mass Eye and Ear sector of Harvard Medical School. It's the ophthalmic division of the Harvard Medical School, and one of their previous directors, a professor called Klaus Dahlmann, developed this. They use cornea in order to integrate between our own human body. They take donated cornea tissue that's not suitable for transplantation because it's not transparent enough, and they use that to integrate between their artificial. And the other one is the osteodontokeratosis, which uses a part of your tooth and your bone to integrate it with the eye. And our device doesn't need any donor tissue. So in areas where you don't have any tissue banks, you can use our device. It can sit on the shelf and wait for the patient. Instead of asking the patient, listen, we have donor tissue, you have 2 days to come, and you have to stop your life for the next month because you're going to be an organ transplantee. So instead of doing that and halting the life of someone in a moment that somebody else died, and now you have this tissue and you need to implant it now, otherwise the tissue is not viable. It has a week between harvest and possible transplantation. So here we have a device that sits on the shelf so we can time the procedure. And maybe the key point comes from an engineering, let's say, perspective, and we integrate the device into the white part of our eye, whereas all previous attempts tried to integrate it to the cornea. And the cornea is a transparent tissue, so it doesn't have any blood vessels and has very, very few cells, and it heals very, very poorly. Even if we get wounded there, it takes time. And whereas the white part of our eye, every time we have a small inflammation, you immediately see it congested and red because the blood vessels there, they immediately attack whatever is coming at them. So we use this virtual space. We were able to show that using this, we create robust integration for the long term. So this is from the mechanical, let's say, engineering aspect, a different connecting site. So we have two projects in glaucoma. One is a clinical trial that just started in Toronto, Prism, with Ike Ahmed, and another center is at Toronto Western, David Ruckman, for the patch. It's a patch to conceal glaucoma and other irritating implants, and we have already implanted 5 patients, and so far it looks very good. And the third project, which is entering animal trials now, is a glaucoma drainage device called the eShunt. Again, using advanced chemical engineering to try and imitate our own drainage pathways, but synthetically, similar to the way we try. I use this chemical engineering to try to fool the body into believing a completely synthetic cornea is actually biological and it will integrate. Try to use the same logic and create glaucoma drainage device that imitates its own drainage apparatus in the eye, giving a physiological pressure following the implantation. And so this is the third project. We have already written IP in other fields of medicine as well. And we have a project going into initial steps in periodontology, in dentistry for gingival recession. And future projects will probably also be, we have been approached by orthopedics, general surgeons, gynecologists, and so forth, because our core competency is creating an artificial, let's say, extracellular matrix or an artificial micro tissue skeleton. And the minute we put that within our body, the cells are fooled and grow into it, similar to, let's say, an ant farm. When you have a child and you buy an ant farm and he puts the ants inside, and the ants don't know that it's not outside. They believe that it's their ant farm and they live and they make their house. The cells are fooled in a similar way to grow into our matrix and embed it within our own body.